my office is turning into a COVID testing site, and I am grateful for all of my neighbors and my surrounding clinics who are giving us space to work and continue to see our patients. I'm also grateful that this pandemic happened when my kids are teenagers and can care for themselves while my husband and I are out of pocket so much.
Welcome, Mary. Really glad to have you and the service that the FHC is providing to our community. Tom, if you can. Oh.
Hi there.
Oh.
Make the camera go on and off. Tom Michaels, manager in population health for behavioral health and social work.
Welcome, Tom.
We're doing word of the morning.
Yep.
Ambitious. We are pivoting half of our department in order to reallocate resources to the coronavirus outbreak.
Ambitious. Our friend from Pitt, Peru.
Hi, I'm Dan Lamaro. For those of you who don't know me, I am originally from the Lehigh Valley, but now I live and work in Pittsburgh with the Pitt School of Pharmacy, and we collaborate closely with some key individuals from Lehigh Valley to help with the MOUD implementation work.
Gina, you here?
Yes, hi, I'm Gina Hills, program coordinator for the Center of Excellence at Neighborhood Health Centers in the Lehigh Valley. And my word for the day is lucky. I feel lucky that I get to be here and part of the ECHO faculty and work with really great people like Abby, Naomi, and Jazz every day.
Nyan. Thank you, Gina. Really glad you're here.
Good morning, everyone. I'm Nyan Beery. I'm with the Department of Family Medicine. I do the research and evaluation for all of this work. And my word of the day is running behind already.
Behind already. Kim.
Good morning. Sorry, having trouble with the video, but I work with the Department of Family Medicine, and I'm working from home today, and that's my word of the day. Thankful to be able to work from home and sort of avoid a little bit of the craziness.
Welcome, Kim. Drew. Oh, hello. Oh, you're muted, I think. I don't hear you. You're not muted, but maybe your microphone isn't working.
Sorry, I was not muted in the Zoom, but I was muted on my phone. Apologies. So I'm Drew Keister. I am the Vice Chair for Education for the Department of Family Medicine, and I practice at the Family Health Center, which my lovely wife just said a few minutes ago is moving. So excited to see how we can help that happen. And my word of the day is cold. I just got back from a walk outside, so I'm chilly.
Welcome, Drew. Great to have you. Lynn?
Hi, guys. I am Lynn Wilson. I am a family physician and geriatrician with the Department of Family Medicine. I also work at the Family Health Center, and I am trying to work from home with 3 kids under the age of 6. So I would say my word for today is crazy.
Crazy. Welcome, welcome, Lynn. 610-657.
Hi, good morning, everyone. Could you guys hear me?
Yes, we hear you.
Good morning. This is Julia Yurkevich. I'm calling from 17th Street. I'm practice director with LVPP Specialties, our Community Health and Wellness Center, and Centro de Salud. Thanks for having me. Also, very thankful. It's been an interesting week so far. Every day has brought new challenges, but very thankful for the amazing colleagues at 17th Street that are rallying together and making this feel a little bit easier.
Wonderful. Welcome.
Thank you.
610-462.
That's me, Paige Ross.
Paige.
Yeah, sorry, it's not letting me log on from home, so I have to do the phone. So I'm guessing we're checking in. I'm Paige Ross. I'm the program coordinator for addiction recovery services at Lehigh Valley Health Network. And I'm a little frazzled, but grateful to be okay. I just found out my daughter has daycare issues, and could I watch my granddaughter today? And I'm home, so I said, sure. So she'll be arriving in a little while, so I'll stay on as long as I can.
Great, Paige. Really glad to have you for every moment that we get. Jillian. Yep, you're muted. Jillian. Sorry, we've got.
There we go. It gave me a crazy message about control alt something and then went away. All right. I'm Jillian Beecham. I'm with Department of Emergency and Hospital Medicine and Division of Medical Toxicology at Lehigh Valley Health Network. And I am grateful to be able to spend the morning with everybody here talking about this work.
So glad to have you as part of our group, Jillian. Kevin and Amy.
I'm Amy. Oh, good morning. Can you hear me?
Yes.
Good morning. My name's Amy Janan. I'm one of the registered nurses. I work with Dr. McNeil here in Hamburg. And my word of the day is definitely hopeful and hoping that things, return to our norm very soon.
And Kevin. Oh, Kevin, I think you froze. We'll come back to Kevin in half a second, but Kevin, we're coming back to you. Angie.
Good morning, everyone. I'm Angela Callistra. I'm Director of Behavioral Sciences from Family Medicine and oversee behavioral and addictions integration for the PACMAT. I am feeling excited about the ECHO this morning, but also quiet. I don't want my kids to locate me when they wake up.
Wonderful. Really wonderful to have my Zoom buddy in our midst at Lehigh Valley now. Yamalisa.
Good morning, everyone. I'm Yamalisa Taveras. I'm the Project Director of Counseling Solutions of the Lehigh Valley, also hiding from my 6- and 4-year-old who are still asleep, so hopefully they don't find me either. And word of the day, or really of this, everything that's happening is hopeful that when we come out of this, we become more kind to other people and understand that this is a reality around the world in other levels, and now we're feeling it. So we'll see how we do.
Welcome, Yamalisa. Wonderful to have you. Kevin, can we try you again? Since we didn't hear Kevin. Oh wait, where did he go? Kevin is relogging in. Bart.
Yes, can you hear me? Can you hear me? Yes. Oh, okay, good. Hi, this is Barb Kazouasis. I'm with Department of Family Medicine at Lehigh Valley. I'm here to sort of observe, and I can't decide between thankful and hopeful. Thankful that I'm working from home and I got all this technology figured out. I've got a big old monitor so I can do some detailed work today, and hopeful just that the day goes smoother than the last few.
Wonderful. Thank you, Barb, for everything that you do. Naomi, I would love for you to introduce yourself.
I am Naomi. I am one of the ECHO specialists. Just came on board, so it's my first true ECHO, and I am actually blessed to be here.
And do you have any particular interest in this work or any kind of?
Yes, I'm actually a CRS.
What's that?
CRS is a certified recovery specialist. I also work here at NHCLV as for the Center of Excellence as a community healthcare worker as well. I'm also a certified peer specialist as well.
Welcome. Thank you. Jack.
Hi. I'm Jasmine Irizarry. I'm one of the registered nurses here at Neighborhood Health Centers of Lehigh Valley, and I coordinate the ECHO clinics, and I work with medication-assisted treatment and the Center of Excellence program here.
What's your word for the day? I didn't get
that's
Naomi's
right.
either.
I am hopeful that we all, just like Yamli said, that oops.
Our lights turn off in this room.
There we go. You are so. I'm hopeful that we all learn from this experience, just like Annalisa, and we all become grateful for each other and know that the world is so much bigger than the small little place that we find ourselves in every day.
And I see that Amy relogged on. Amy, do you have Kevin so that Kevin can introduce himself?
I don't have Kevin. I am at home by myself.
You're a different Amy. Hey, Amy.
Oh.
Welcome, Amy. Tell us, let's check in of just who you are, where you're from, and one word for the day.
Okay. Who I am, I'm Amy Smith. I am medical educator in the Department of Education at Lehigh Valley. A lot of my work is with the select medical students, which is my interest in this, is to take whatever back to the students. What were all your questions? I'm sorry.
One word for the day.
Oh, my one word for the day is relationships and keeping the social relationships. This is so important to be able to connect like this and to connect with each other and support each other and not to be physically distant but not socially distant. So thank you for having this.
Welcome. And I'm Abby Letcher. I'm a family doctor here at the Neighborhood Health Centers and one of our doctors in the MAT program here, as well as co-director with Jillian for our PACMAT. And it would appear to me that my word for today is welcome. So we're going to get started. Today, we'll start with our didactic, and I think it's going to be something that's fairly basic that we can go through pretty quickly together. And then we've got 1 to 2 cases that we can go through together. In the future, I want to sort of hear your feedback as we're ready to go. You can chat if you need to leave early, or we'll see if we have time to just get the feedback in person. I think what we'd like to do is start with one case, do the didactic, and then finish with a second case, so people who can only do 1 hour will be able to still have time to review a case. So let's see how I am on the sharing of screens. Can you see the presentation? It's coming, it says. Maybe. Yep, there we go. Okay. For those of you who were part of our ECHO last year, you may remember that we are using curriculum that was developed by the Project ECHO Institute and the partners that you see along the bottom of the banner here, some of our real leaders in addiction medicine and in collaborative behavioral health. Minor alterations, and they've distributed these for us to be able to use in Project ECHOs around the country. So we're very grateful to Miriam Kamarami and her partners around the country who put together a really wonderful way to help us think about treating opiate use disorders in primary care using the chronic care model. None of us have anything to disclose. And our objectives today are the very basic. What are opioids? What does intoxication look like? What is this epidemic about? What are the harms? And then the real didactic nugget is the criteria for opiate use disorder and diagnosing opiate use disorder, with a brief touchdown on what's the role of the primary care team and how to confront stigma. So like I said, this is the very starting point. Okay, and I don't know how to turn off the sound on my email, so I'm sorry if it dings. It's kind of distracting. I'll figure that out before next month. So opioids, opiates, I think most of our team here knows that these are chemicals that are both naturally occurring and synthetically created to mimic the effect of the naturally occurring. The opiates are the ones that are natural. These come from the opium poppy, includes opium, morphine, codeine. The opioids are our synthetic chemicals, which are the heroin medications like hydrocodone and oxycodone, fentanyl, tramadol, methadone, etc. I think one of the things that's useful to remember about that, and in a future echo we'll talk about, knowing the difference between these is mostly helpful for interpreting your urine drug screen. They act in the same way, more or less. Their effects, we know that all of these drugs have a potential for physiologic dependence. Oh, there's Kevin and Amy back. And we use them for lots of things. And in the recent past, we've used them frequently, and now thinking about how to use them more judiciously, mostly for pain. They can cause constipation, sedation, respiratory depression, and of course, overdose with respiratory arrest. So, team out there, let's just go with which one of these is not an opiate. Anybody can just join in there.
Alcohol. Alcohol?
Alcohol is not an opiate. You're correct.
Mushrooms.
Not an opiate. Correct.
Marijuana.
That's correct. Marijuana is not an opiate.
Cocaine.
Cocaine is not an opiate.
Methamphetamines.
Got it. I think that's all of them. You guys are stars. One reason to notice that why this slide is here, though, is that for many of our patients, they are a little confused about which medicines are opiates and which are not. So being able to answer those questions and remember that some of them people aren't so aware, particularly the tramadol is one that gets confusing for people. And the question about some of these other things, is cocaine an opiate or not? Those are questions that we've all heard at some point or another. We know that opioids are effective for acute pain. There's been a big push in the last 5 years for really to reassess how we've been using opioids for pain. Very effective for acute pain, but probably much less effective than we thought for chronic pain and causing some of its own problems, including the hyperalgesia. It's as part of our history as clinicians, we are often trying to work with partial knowledge, and one of the things that we did know in the 90s and early O's is that there was a lot of bias in how we were using pain medications, and I think one of the real drivers of prescribing opioids was a desire to have some equity, and we knew that African Americans in particular were being under treated for pain, and then we started having some programs like pain is the fifth vital sign, and opioids were prescribed in large numbers and doses. So there was a setup for us for an opioid epidemic. So what are some of the signs of intoxication? Jillian can't answer this one because she's a medical toxicologist. But anybody else, what do you see for intoxication?
Sleepy.
Blurred speech.
Mm-hmm. What was the other one other than sleepy?
Blurred speech.
Mm-hmm.
Nodding off.
Yeah.
Same thing. Sleepy.
Yep. All that.
Erratic behavior.
Yeah, though often for the opioid not so dramatic, people are pretty chill when they're intoxicated. A little high.
Pinpoint pupils.
Mm-hmm. You got it. Okay. And then from there, the drowsy and sedated can get to overdose. What are some of the problems that you see with opioid use disorders or opioids use? And this is just as simple as it sounds.
Oversedation.
Mm-hmm.
Respiratory depression.
Yeah. Mm-hmm. This is our big one, overdose and death. We hear a lot about that with the respiratory depression. One thing to note is that, we talk about addiction and opiate use disorder. We use the term opioid use disorder as a less stigmatizing word nowadays. But addiction, that's a major problem that we see with the opioids. What other kind of problems do we see that are kind of associated with the use of opioids and opioid use disorder?
Relationship issues.
Yeah, big relationship issues.
Also jobs,
economic issues.
Homelessness,
absolutely.
Criminal activity.
Mm-hmm. The spiral just keeps going, right? Complete unraveling of people's stability in their lives. So we've been through this a fair number of times, the fifth vital sign, pharmaceutical company promotion, overprescribing, diversion, and then the flooding of our markets with heroin and then fentanyl without much access to treatment, medication treatment, or other treatment. You guys have seen these slides. We don't need to go through them, but the big idea is that the opioid prescribing came first with the blue line, and then the heroin came second with the red line, and our more recent maps then show that exponential curve of the fentanyl hitting the market a few years later. From our DEA partners who study these things, we know that prescribing has gone down in Pennsylvania, and that's exciting that there's been a real curb on excess prescribing. And we see that also at a national level, that the prescribing is on a curve downward, and yet the overdoses are only have been going up in many, many communities still, and require an interdisciplinary team to help bend that curve down. This is the 2017 map. I think there's some 2018 data that's come out pretty recently. But our overdose deaths, you can see in our communities, are quite high. Not as high as the western part of the state, but still, this is the high cost of human life with the opioid epidemic. This is true in all age groups. Young are dying, and so are our elderly. Often the elderly are overlooked when we think about the opioid epidemic. I think at NHCLV, we actually see quite a few older patients, and these are folks that have had issues for quite a long time and may have had some periods of stability, but now with the flooding of the markets, it's hard to get away from the opioids that are out there on the street. Fentanyl, of course, changed everything. If anybody wants to talk about that more, we can head back to it. But we would say, and Jillian, you can chime in here, but pretty much 100% of our urine drug screens at NHCLV that are positive for opioids include fentanyl in it. Is that what you're seeing in the ER also, Jillian?
So we're not testing for fentanyl in our standard ED urine drug screen, although that has just changed.
Mhm.
So we know that fentanyl is present, but haven't been picking it up. And so I think that's maybe the case in a lot of rapid urine drug screen testing out there. So I'm glad NHCLV is doing the point of care test for fentanyl.
We actually don't do the point of care test for fentanyl, but if the opiates are there, we send it.
Oh, gotcha.
We see the fentanyl that's there. And what's actually, and this is somewhat off topic, but the fentanyl sticks around a little longer than the heroin and the heroin metabolites, so it's often what we see. And I think one of the surprises for our medical community was how difficult it is to reverse fentanyl overdose because of the potency. Probably another thing that we're hearing from people who are educating us about what's going on out in the streets is that the fentanyl is so potent that people will specifically look for the more dangerous, more potent supply, even when they know that the risk of overdose is huge. And while some people do carry naloxone with them, you may need multiple instances of the naloxone for a high dose fentanyl overdose. We hear from our first responders sometimes 5 or 6 doses of naloxone, and it doesn't last long. So what is an opioid use disorder? What we call addiction. And I think the main point here is that our ASAM, the American Society of Addiction Medicine, is very much using language to help us, particularly us in the community and in primary care, wrap our heads around the idea that addiction is a primary chronic relapsing brain disease. This is chronic disease management that's characterized by an individual pursuing reward or relief by substance use and behavior in a way that's pathological. And when we look at the criteria for the substance use disorder, you'll see that it sort of focuses on how do you know that what does pathologically pursuing reward or relief look like, and we'll get to that. But physical or physiological dependence on opioids is not the same thing as an opioid use disorder or addiction. So here are our DSM-5 criteria for opiate use disorder. And I like to think of them in terms of the dependence, which is over, I don't know if you guys can, no, I can't even see my own pointer. Withdrawal or tolerance are signs that you're physically dependent on the drug. Those are criteria for an opiate use disorder, but they have an asterisk there, and they have an asterisk there for a reason that I'm sure somebody can shout out to me. What's that asterisk about? You can read it for one thing. That if someone, go ahead.
Yeah, it means if they're being prescribed, Abby, that tolerance and withdrawal is expected, and that wouldn't classify as signs of an opiate use disorder under a prescription.
Right. So in that case, you'd be looking for another one. And then we think about the rest of the criteria in terms of control of the drug use or the consequences of the drug use. So not being able to control that use is seen in using larger amounts or longer. I tried to quit, but I just couldn't. Or the cravings, whereas the consequences are more of the ones that you see of the hazardous use, repeated use in risky situations, social and interpersonal problems. But it's a good idea to have these criteria available at NHCLV. We've put them into our templates when we're talking to people about their use of substances so that we can go through them. And it's often a great way to help our community understand also what are the consequences and the signs of a use disorder, and that it's about the control and the loss of control and the negative consequences, and continuing in spite of negative consequences. As you all know, 2 or more of these criteria are a mild substance use disorder. 6 or more is a severe substance use disorder. And with opiate use disorders, most of the time we're seeing people in this severe category. When they come here for treatment, when they're going to the ER after an overdose, they often will endorse all of the criteria. Okay, so let's think about this one. Ready? 37-year-old man prescribed opioids for pain after his motorcycle accident, multiple surgeries. He's been receiving prescriptions for opioids for many months, let's call it over a year. He tells you that the analgesic doses that he's been prescribed aren't helping to control his pain, and he's asking for a higher dose or a more potent formula. How do you decide if he has an opioid use disorder? Kevin's leaning in.
Some of the things, in addition, of course, to asking him about increased use and how it's impacting his life, also checking the PDNP to see if he's asking from other prescribers, checking urine drug screens to see if he's using other substances. That would help.
Do you know from this story whether he has an opiate use disorder or not? Gina says no.
No, I would say that you'd need more information before you'd be able to make that diagnosis.
That's right. We know that he's been prescribed these medications, and the two criteria for the opioid use disorder that we know from this vignette is that he has what?
He has tolerance, and that's one of the asterisk ones that we would expect that if he was being prescribed them and taking them as prescribed.
Right, and that's the only one that we know. It doesn't actually say anything about withdrawal. And we know that that has an asterisk, that we expect that he would develop some tolerance. So we need to know more. Great. How about a 52-year-old woman, high doses of opioids, more than 180 morphine equivalents for chronic pain for her inflammatory bowel syndrome. Patient's former physician has left your practice. She's transferred to you for care. You note that the prescription monitoring program that Kevin mentioned, that she's had opioids in 2 different emergency departments in the past month. The front desk staff tell you the patient has recently lost her job and is getting divorced. How do you decide if she has an opioid use disorder? What do you think? Are you worried about her?
It would definitely be a concern because of the situation that's presented. More information still needed. However, it appears that she is dependent, so it is a higher level of concern because of the amount that she's using and the drug-seeking behavior that she's presenting.
Thank you, Yamalisa. Anybody else have anything to add?
It'd be interesting to talk to her to see what led to what. Substance use led to the social consequences, or the opposite is true.
Right. So we do see something that could be negative consequences of the use, and it may not be. They may not be related to that use at all. We see something that could be drug seeking, going to different hospitals, but it also may be that she had flares and that was an appropriate treatment. So kind of an interesting set of questions. We don't know for sure, even if there are a lot of red flags there. But she could tell us a lot more about whether she's experiencing some of those other negative consequences, and how things are going for her.
One of the things I think that's interesting about that scenario is, and maybe this was just said differently, the loss of job and divorce, if they're not a consequence of her drug use behavior, they certainly make her vulnerable to a drug abuse scenario.
That's right. And so these causes and effects can be very complicated and circular and self-reinforcing and difficult, right?
Abby, I don't know if you can see the chat, but Candace said that she could be diverting too.
Oh, yeah, I did not see that chat because I have on mine is the PowerPoint. Thank you, Candace. Very good possibility too. And how would we find out about that?
I would ask her if she's, using all the medication that she gets herself, or if she's sharing it with somebody, and in a non-judgmental way, because I'm somebody in recovery, and I know that happens sometimes, or if you need money, you're willing to share your medication. So I would just ask her.
That's beautifully said, Paige, that when we ask without having already jumped to a conclusion and collected all the emotion that goes along with that conclusion, if we can ask in a way that's open and caring and shows that our main concern is someone's safety, people will often tell us what we need to know. So thank you for making that point so beautifully.
So Candace also mentioned you could do pill counts and UDS and review the pain contract.
Oftentimes we're checking the point of care urine drug screen to make sure that the drug we prescribe is in the urine. So exactly, thank you. All right, a 19-year-old, large abscess, track marks both arms and hands, and acknowledges that she's been injecting heroin several times a day. She's been trading sex for drugs, recently released from jail. How would you approach this patient? I feel like I saw her yesterday.
So she would have likely have a severe opioid use disorder.
Can you describe why you think so?
Yeah. Well, she has track marks on her arms, and she's using heroin several times a day. So in addition to using daily, I would expect to find tolerance and withdrawal. She's been incarcerated, so it tells me her social and emotional and relationships and what did she do to become incarcerated was likely due to her heroin use. In addition to her trading the sex, we know there it's due to her heroin use. So I think just pretty quickly we could find 5 of those, 5 if not all of those diagnosis marks. Yeah, so certainly a lot of physical and emotional support in addition to treating her withdrawal is going to be needed just to stabilize her. But I think first things first is around treating the withdrawal that she's going to be experiencing pretty early on, so we can get to the physical and emotional treatment around the trauma that she's likely experienced.
Thank you so much. Any other thoughts on this one? What comes up for you about how am I going to approach her and what kind of physical and emotional care could she need? How are you going to talk to her about it?
I just think as Paige mentioned a few minutes ago, that kind of an empathetic and compassionate approach is absolutely key here, and that it requires a reset, especially if I think for those of us who work in healthcare, to say, before I go in the room, I need to reset and leave my judgment at the door and ask myself and ask the person in front of me, what happened, that got you to this place? What have you been through? Rather than, why are you doing this, right? So what trauma has she been through? What would have been her adverse childhood or life events, and to really reset and try to provide her with as much compassionate support and understanding as possible.
Wonderful. And I think we've previewed many of the themes that will come up over the next 12 sessions. There's a lot of beauty in this work and a lot of great skill in our community, and I'm really looking forward to our discussions. So then our next brief overview is what's a primary care team to do, and what does this have to do with primary care? One, which our Kevin McNeil is a great expert in, is responsible opioid prescribing. As we know, at Lehigh Valley Health Network, Jillian and Kevin are both running our opioid stewardship and linkage to treatment group, which has focused in the last few years very much on helping practices with safe opioid prescribing and applying these CDC guidelines. In the moment, sometimes these things that look very easy to do or hard to document correctly. So I think a lot of the work is yet to be done to help us do this in ways that are consistent for our high-risk populations. But number one is prevention. We can also be screening. So there are SBIRT protocols, the screening, brief intervention, and referral for treatment. How do you detect and intervene early if you can find people who are developing a problem? We know for alcohol use disorder and for smoking that screening in primary care offices actually has an effect in preventing risky behavior from progressing to a use disorder. We can prevent diversion. We heard from Candace about monitoring people closely, using the PDNP and the urine drug screens and pill counts. Harm reduction, we didn't mention with our last case that one of the things that we can do for her is give her some Narcan to go home with and make sure that she knows about the problem solved about using clean needles and not sharing. So those are things that we can also do in primary care, screen for the infections that we know are associated with use disorders. And then there's treatment. We can use medication treatment for opioid use disorders. It's really effective, evidence-based. And so we'll be focusing on that quite a bit with the cases that we address coming up. And then also screening for co-occurring disorders, folks that have been struggling with use disorders over a period of time often have not been able to pay attention to other physical, mental health challenges and experience a real deterioration in their social determinants of health. So need a lot of help with those things too. So even if you're not doing all of these things in primary care, every primary care office can be doing some of these things. So we're excited to help our primary care practices partner with community and our community to partner with primary care practices so that we can implement more of this in primary care practices. Which brings us to stigma. I think one of the reasons that practices have not done this as much is related to stigma and to some feeling that that these people are different from people with other chronic illnesses. So there's a lot of stigma. One of the things that we'll be talking about more, and there's been some wonderful work that Paige and Jillian have been heading up about reducing stigma. I hope you all have your no stigma buttons. But how we talk about people with people and how we talk about people amongst ourselves in our offices can have a huge impact on our ability to partner with our patients and offer them support and help for their substance use disorder. So when people come and they hear language that goes along with judgment or stigma, when they feel the microaggressions that go along with judgment and stigma, when they encounter barriers that are set up with assumptions that are based on stigma, they don't come back, or they don't come at all until they're compelled to, and often then may come up in ways that perpetuate the stigma even more. So our job is to make sure that we're creating environments that are welcoming and nurturing for people who are looking for care that are often coming to us really hurt. So that's my soapbox on that. What are some of the situations where you've seen some stigmatizing behavior or language related to substance use disorders? Let's just talk about that for a couple of minutes and we'll get to our cases.
Well, this is Paige. So I have an issue with the word addict, and I don't like to hear healthcare providers referring to patients as addicts, whether they are addicted or not. That it's a bad term, and it's extremely stigmatizing, and all the words that are related to that word are just, it's just bad. And I think it immediately puts people, they've been labeled, and it's just, I wish we could take that word out of EPIC. It shouldn't be able to be entered along with some terms like drug seeker. These are all, they're just demoralizing, and same with alcoholic. Although, that's a little bit more accepted, it's still, I have an alcohol use disorder. The only place I ever refer to myself as an alcoholic is in a 12-step meeting. Out anywhere else, I'm a person in recovery. So, we need, and I know it takes a while to learn to say, this patient has a substance use disorder or, an opioid use disorder. But it's so important. I can't stress it enough. The word addict should not be used in any practice.
Thank you, Paige. And I think, what I would love is for this group of people to hold each other accountable for that and to help promote non-stigmatizing language in our practices. We use person-centered language in primary care for many other chronic illnesses. We can make the effort to do it for substance use disorder as well. Anybody else that's got some examples or something that they've seen as far as stigmatizing behavior or language?
Yeah, this is Kevin. Well, everyone can see me, never mind.
Yeah.
I think the first thing I had to realize was to identify it, sort of a judging attitude within myself. And I've learned a lot, really come a long way over the past few years through learning from you and Jillian and Paige and others. But I just had this one instance, very, very busy, hectic day. Saw a patient who wasn't a patient of mine. This is a few years ago now. Wasn't a patient I had seen before. And he had a history of chronic pain, was on pretty decent doses of opioids. And I just had this feeling that, feeling in the pit of my stomach. And I think really this real negative feeling about this person. I just felt it physically before I even stepped in the room. And I was just thinking to myself, what on earth is going on here? I think it definitely had an impact on my ability to do a good job at caring for this person. And so, I think there's hope out there because, I've certainly improved. But I also sort of understand that, where that could be coming from and just the power of, knowledge and working with others who know more.
Thank you, Kevin. As always, elegantly bringing some of the vulnerability of how difficult it can be to address our own issues while we do this work. And I think one thing that you mentioned that that I think is powerful is how much of this gets passed through the medical record from one clinician to another that sparks that judgment before we even see the patient. Right? And they can be subtle things. It may not be that there's actual, sometimes it is. We talk about drug seekers, or we talk about frequent flyers, or we talk about all sorts of things that maybe are descriptions of people in withdrawal who are looking for help. And they get passed down through the record, and the judgment is a little contagious that way. So we can think about what do we put in the record. We can think about how we approach people. We can think about how we approach ourselves and prepare to be present with someone who's suffering. All of those things are part of being human and practicing relationship-centered care, right? Any other thoughts about the stigmatizing language and what does it mean to be engaging in this care overall in our primary care settings?
So not exactly about language, but something that's coming to mind that I'll just share. I recently experienced a practice that they designed their electronic system so that when a patient with substance use disorder was identified, when that person came in, it like pinged. So everybody, it was almost like in the old days where you'd use a different color folder, medical file. And so therefore the staff that maybe, had to interact with the patient but weren't real, maybe not as aware about substance use disorder kind of treated those patients differently.
Mm-hmm. Mm-hmm. Well, and it's interesting because we want to use our records to identify populations at risk and make sure that we're providing the care that they need. And sometimes that may backfire, right? And when is it stigmatizing versus when is it actually helping? I think, Rob, you bring up a really important point that while we often start these initiatives with a group of champions in a practice, that the whole practice needs support and needs training for how to manage the emotions of dealing with the effects of substance use disorder in our office spaces. That oftentimes, I'm always impressed, and I'd love to, I think this will come up a lot with the cases and other things as well. But the substance use disorders, it's like 1 degree or at best 2 degrees of separation from everyone that's in the office. Everyone has some experience personally, immediate family, or not very far from immediate family, and has seen how difficult life can be when substance use disorder is in the picture, and many of us haven't had much of a chance to process those emotions. So there's a lot of work to do in the office as a whole to help all of us heal. But what I love is when this work goes really well, there's healing opportunity for everyone in the office, not just the patient. And Kevin, I think you mentioned that a little bit of like starting to notice how does your own bias operate, that you can then all of a sudden you have tools that you can use to try and mitigate or moderate that and grow to have a different response. So may we all grow and heal together. And thank you, Rob, for bringing that up too. All right, that's our didactic presentation. We will shift to our case presentation. Kevin has a first case. Kevin, do you want us to project that, or do you want to share from your screen?
Yeah, I'd appreciate it if you guys could share it.
Yep. Coming up soon.
All right.
So while I'm doing that, I will try to multitask and say the way we do cases with the Project ECHO is Kevin has volunteered a case. Thank you, Kevin. And then he fills out a form that Jasmine puts into a somewhat more visible PowerPoint. And he will go through the basic of the case. And then our ritual follows in this way, that we will then ask for clarifying questions, things you need to know about this patient, other questions you have about the patient. And we'll start with our participants, and then our faculty group will get a chance to ask a clarifying question. And our faculty group, as you sort of heard from the introductions, includes everybody from an interdisciplinary team. So we'll get lots of points of view on this case. And then when we're done with our clarifying questions, then we'll go back around and ask for suggestions or resources for this case. And we'll be keeping track here in the CASA room. Don't know what the background noise is. Vacuum cleaner. We'll be keeping track of the resources and suggestions and be able to get those back out to you, and they'll be posted on the NHCLV Project ECHO website as well. Okay. Kevin, here is your case.
Thanks, Abby. Thanks, Jasmine. So let's just take a couple minutes, and Amy will also sort of jump in, you know, at certain points as we're talking about this this patient who was one of our first patients. We only have 4 at this point that we're treating for substance use disorder in this way. But he came to us, CL came to us from a drug and alcohol treatment center. Amy and I are still not entirely sure how he found us, but we're glad he did. And he came to us after, you know, about 30 days of treatment. So some of the things that I'm be asking for, just sort of any ideas and suggestions, but in general, you know, ongoing assistance with medication and how we can best support his other treatment. And as you can see here, we didn't have a chance to speak to this patient about that, about doing this presentation. I think he's got several strengths, but I mean, he is really fully engaged in treatment, and he's got good family support from his father and from his stepmother.
Stepmother, yeah.
Yeah. I think his mother is also supportive, but you know, but that whole environment, because he used to live with his mom, his mother and father divorced, I think when he was younger, and he was pretty young, and lived with his mother for a while. But the you know, the overall environment and social environment, you know, wasn't good for him, and so he's moved to live with his dad. So we're going to be asking about one of the questions that CL had for us, and I'm sure everyone who does this work encounters this question all the time. You know, patients want to be off of it, and they want to know how long they should be on the treatment. He does, in addition to, well, let me say, you know, I asked specifically, how do I address his tobacco use and his kratom use, if I'm pronouncing that correctly, which he's asked me about, which I, you know, I'll just be honest, don't know that much about, and certainly did not encourage him to continue to use that. So you know, idea about how we should address that would be very helpful. Hey, can everyone still hear me? We've been having some connectivity problems.
Oh, no. Okay.
You can hear me okay? Okay.
Mm-hmm.
So, because the screen is kind of getting a bit blurry. He also,
I want to be with Jillian.
Yeah. I'm just enjoying the presentation too. So there's another question that that I had wanted to bring to the group, and that Jillian and Abby have been very helpful with, but I think a useful thing to discuss is he, I think, being a pretty typical 22-year-old, I think you know, acts a little bit younger than his age. You know, he frequently has irregular sleep patterns, and sometimes he'll sleep late, and then he starts to have he has these withdrawal symptoms. He's yawning a lot and has this strange sensation, uncomfortable sensation in his jaw, and so questions about, you know, how do we address that, besides the obvious, you know, set an alarm and take it at the same time. Would it be okay if we go to the next slide? So a little bit about his history. I'm not sure at what age, but he has a history of ADHD, and he was prescribed stimulants for a period of time. And I think that that's important to know. And then over the years, he's used amphetamines, non-prescribed, marijuana, of course, smokes, and then he started to use heroin, a pretty significant, obviously, step up. And he's had full 4 years of heroin use. And before he was admitted to the treatment center, he was using, by the medical records, 4 bags of heroin a day, injecting heroin. Again, his parents are divorced. He lives with his father now. He had a few semesters of college. I think it sounds like he was sort of in and out. And then he was living had been living with his mother for a while. But again, the place that he worked with, sort of like a chain type of restaurant, it was pretty much daily drug use with the people that worked there. And he really had to get out of that environment. I don't know why I wrote none known for legal involvement. And he's not currently employed, is that correct?
No, he's seeking employment, but is not currently employed. Got it.
Abby had mentioned about they have the point of care testing. As for all of us who work at LVHN, we don't have that DIP point of care testing, but the first testing that you send out is an immunoassay, and so being on Suboxone, comes up positive for oxycodone, but then the quantitative test was negative. So in other words, the UDS has consistently for the past few months that we've been seeing him, since we've seen him, it's always been good, and the buprenorphine is positive, is where it should be. And then we talked about the heroin use, and then he was admitted to this inpatient treatment in December, and this was the first time he had ever been admitted. But interestingly, his urine drug screen was, upon admission, when we were reviewing the medical records, positive for fentanyl. He occasionally uses Klonopin as well. He's used, as we talked about, his past history of cannabis, amphetamines. He also drank alcohol as well. But he stopped that for a while, and his drug choice was really heroin. And then, as I mentioned, he was previously prescribed amphetamine for ADHD. We could go on to the next. Yeah, so he has, based on his past history and based on his diagnoses and symptoms on admission, he had opioid use disorder, severe opioid use disorder. He also has been diagnosed with depression, generalized anxiety disorder, ADHD, and tobacco use. And he's on Suboxone 8 and 2. He was 1 sublingual a day was what they had prescribed for him and what we initially continued. You can go to the next slide. So he's currently in counseling at the Schuylkill Counseling Center. He's still in IOP 3 times a week. Is that right? Is he still doing that?
I think it's decreasing as of this week.
This week it's decreasing. And goes to counseling weekly. Was always recommended by us as well as his counselor at Schuylkill that behavioral health counseling would be recommended in addition to his weekly counseling. They also recommended, and we supported, the increased frequency of those mutual aid meetings, NAAA, whichever one. I think he goes to both right now. Is that right?
Yes.
Yeah. And we regularly screen as part of our protocol. We just regularly do the PHQ and the GAD score. And so he still has some symptoms of depression or anxiety. He has not wanted to treat that with medication. And I don't think he's been set up for, has he had
He has an appointment with.
Oh, perfect. So
Next week.
So our wonderful counselor here, Gloria Robinson, will start seeing him as well. So his primary motivation for inpatient treatment was that he just had complete disruption of his life, jobs, his relationships within his family, and then I already mentioned about not a great social environment that he was living in. Again, I think his mom was supportive, but overall it just wasn't a good environment for him, supportive environment for him. His father is very involved in treatment and actually, sort of holds the medication and doses it for him daily. But that's a mutual agreement. They're both on board with that plan, with him and his father. So his opioid use disorder, anxiety disorder, depression, ADHD, and tobacco use. And so we want to continue the same dose of Suboxone, working for him. Amy has been critical in doing what needs to be done for contacting the counseling center, the pharmacy, making sure that the pharmacy has the medication if there's prior authorization that needs to be done, et cetera, and also insurance and cost issues. And so we just recently had changed from sublingual to tablet for cost due to, I think, a high deductible. Anything to add about that?
No, just that he's happy with the change.
Okay.
He's had no problems. I talked to him this week, and he's had no side effects or anything like that since the change.
Wonderful. And obviously to continue counseling, he's seeing our embedded behavioral health specialist here. He's going to be completing the IOP. And then we'll continue to talk to him about whether or not it's appropriate to add a SSRI for his treatment. For his depression.
Okay. So I forgot to mention that one of us summarizes the case. Were you taking notes on that? Yeah. Okay, great. So we will have a summary.
Yes. We have a 22-year-old mixed race male with 4 years of heroin use. He has some support. He has a good amount of support from his family, specifically his father and stepmother. He's had some inpatient admissions before. He had one before, and then he came to your office, and he's currently taking Suboxone. He's been taking it for the last couple of months in UDSs or urine drug screens, as expected. He also has some depression, anxiety that also needs to be treated along with the opioid use disorder. And the questions that you have for the group today is how long should the duration of treatment for Suboxone last, and how to address tobacco use and kratom use while also treating the opioid use disorder. And then also some tips that you can probably share with your individual on how to help with morning withdrawal symptoms. And it sounds like you guys discussed already setting an alarm, so maybe if there's another trick or tip on top of that can be used, possibly help with this morning withdrawal symptoms.
Terrific. Sound about right, Kevin?
Yes, thank you.
Okay, so let's turn this back over to our participant group, and I'll stop sharing this so that we can see each other a little better. From our participants out there, what are some of the clarifying questions that you have for this case that Kevin and Amy may be able to answer for you? What else do you need to know about this case? And just unmute yourself and shout it on out, it's fine.
I'd probably want to get a really good handle on how things are at home, like what his relationship is with his stepmother, with his dad. Does he still see his mom? And I'm interested in hearing what Jillian thinks as far as duration of remaining on the bupe, because I tell patients, you can really theoretically be on it as long as the rest of your life, but I would like to see him get the anxiety and depression under control before he would attempt to start with being weaned off of the bupe.
Thanks, Paige. And you're wonderful. You're right on. And let's keep the suggestions for the next round of So just the clarifying questions first. Okay. So hard to keep ourselves to that. We're so tempting. Okay. So more questions. And Kevin and Amy, feel happy to respond to anything that you know, but also it can be helpful to hear what kind of questions do people have that maybe you didn't think of. So other questions, folks?
Hi, everyone. This is Lisa. You mentioned that he is seeking work at this time and has family support. Any other activities that he has listed or any other interests that he has mentioned?
That's a great question. We're not aware of any. When I asked him initially at the first time I saw him, what his goals of treatment are, sort of going through the treatment agreement, it's very helpful in that way. And he had sort of he had one specific treatment, which is our goal was to complete his bachelor's. But then he wanted, and he had, that was one specific goal. The next specific goal was that he wanted to, he just never wanted to take opioids again. Very specific. That was a very specific goal. And then he just wants to have a good job. He wants to have a family. Those are his overall goals. But I didn't ask specifically about sort of day in, day out, what is he doing with his time? It's a great point.
Thank you. And then another, I guess, follow-up question to that to help clarify. You mentioned schooling. Did he say what degree he was seeking?
No,
Okay.
no, I didn't ask that actually.
Okay. Thank you.
It's great to have a team. More questions out there? Clarifying questions. Gina? Still muted?
Okay, can you hear me now? Perfect. Quick question. When you say he's attending IOP, is he attending IOP that is a dual facility that addresses mental health, or IOP that just addresses addictions?
Just addiction, I believe.
Yeah, it's just addiction, but we have the behavioral health specialist embedded here.
Okay, thank you.
That's just about to start, I think, right?
Correct.
Right, okay, great. Any other clarifying questions?
Does he have any friends who are in recovery? Like what does his support group look like?
Yeah, Paige, great question. We need to ask him that. We don't know.
Mm-hmm. Yeah, early recovery can be a lonely time, right? Angie.
Yeah, I didn't want to go if all the folks still had questions. So Kevin, great case presentation. So tell me a little bit, do you know anything about the kratom use? Like how much of that he's taking, or what did he share when he shared his kratom use?
Yeah, he found that it was that, well, he was asking me whether or not I thought it was, he brought it to my attention, which I was very grateful for, and I thought was a good sign that he was interested in using this, and he thought that it might be helpful sort of long-term with not really some symptoms of withdrawal so much, but just sort of another substance to kind of make him feel better. And so I really just dissuaded him from using it, or but I didn't take a deeper dive into, what he was getting out of it, and specifically at this point, how often he was using it.
Perfect. And tell me a little bit about what are his goals around his tobacco use?
So the tobacco use, we kind of put that on the back burner, to be honest.
Yeah.
Figured we'd wait till he was sort of, he's been stable in treatment, but wanted to sort of make sure he was stable for a while, and then we'd address that. So we don't have a plan in place for tobacco use yet.
And did it sound from him that he was interested in one, or that's not something that's a priority for him?
It's something that I didn't ask him directly.
Okay. No. And when you say his morning withdrawals, what is he experiencing in the morning? What withdrawals is he reporting?
So he had symptoms where he was yawning a lot, and he had this really almost like a muscle spasm, but a very uncomfortable feeling that he had specifically in his jaw. And those were his symptoms. It was yawning and just uncomfortable sensation in his jaw. He also had some GI symptoms that Abby and Jillian sort of helped me with. Initially, sort of uncomfortable feeling, not quite constipation, just sort of a upset stomach, and is really how he characterized it. And that has since, not clear to me why, because we talked about possibility of making some medication changes, and Abby had mentioned the importance of talking to them about how to prevent constipation, but those symptoms for whatever reason have resolved. GI symptoms.
Yeah.
And also the yawning and the jaw discomfort last time was not an issue. I think it's because he has been taking it, as prescribed, and taking it about the same time every day.
That's where my next question. That's all for me. Thanks so much, Kevin.
Thanks, Angie.
Jillian, do you have any clarifying questions to add?
Yeah, does he report specific goals around wanting to wean or stop the Suboxone, or is it just that he has some general questions about duration of, typical duration of treatment?
He had general questions about duration of treatment, but he did let it be known, really at the first visit, that he would like to ultimately be off of the Suboxone.
I have another question.
Yeah.
For the bupe, is he on the strip or the tablets?
He had been on the strip, and then we just changed it to the tablet due to cost.
Okay, so is he doing like half a dose at one time and half a dose at a different time? Or
no, he takes one dose in the morning. And Amy was in close contact with him really kind of throughout, but especially with his change in dose to make sure he was doing okay.
Bill Ryan, I would love for you to introduce yourself, and if you have any clarifying questions, that'd be awesome. Are you there? I think Bill has probably stepped away from his implement.
No, I'm right here. I'm right here.
Hey,
I just had some trouble with the audio.
it's hard sometimes, isn't it? Can you introduce yourself, since we didn't get you in the first go around, and if you have any questions?
Yeah, my apologies for being late. We had a little bit of traffic issues today with an accident on the road, so I've had to reroute myself. So I apologize for being late. Bill Rowan, I'm with the Lehigh Valley Hospital Schuylkill Counseling Center up here in Schuylkill County at the Eastern Region campus. And we do outpatient behavioral health, outpatient substance abuse treatment, here. I don't have any clarifying questions. I've been listening and writing notes down. I don't have any specific clarifying questions, and this was good to hear from everybody's input. But I don't know if anybody has any clarifying questions for me that I might be able to answer. This has been helpful, and I'm taking down some notes here that on the questions that are being asked that might be helpful for us to consider for overall treatment planning.
Great, thank you, Bill.
Mm-hmm.
Are there any more clarifying questions from Jasmine?
Yeah, sure. I heard you mention that one of his goals was to be off of any type of opioids for like in the long run. Did he mention that that's one of the reasons that he wants to be off of the Suboxone, or is asking how long he would have to be on it because he has a belief that that being on that is considered being on an opioid in his opinion, so that's why he has a goal of being off of it so quickly or sooner?
Yeah, it's a great question. So really, I need to explore further why, his reasoning. He it was early on. He hasn't brought it up since. And my response was that, it's best that we find that, I guess I was pretty now that I think about it, pretty pedantic, but was telling him that, and telling him sort of what to do, rather than having come at the decisions together. But he seemed to sort of accept that, like I thought it was best for him to stay on the medication, and we can talk about it further down the road in a general way, and he didn't bring it up again. But I think it's a great idea. I should have, it would be helpful for me to explore that further, why he wanted to get off of it, and what were his reasonings, what were his thoughts about treatment.
Great. Jillian, did you have any questions?
No further questions for me.
Okay. One question that I have for you, Kevin and Amy, when you're talking about, you mentioned that he had the ADHD diagnosis from before his substance use started. Do you have any sense of when he started experiencing depression or anxiety symptoms? Was that before his drug use, during his drug use?
Yeah, my sense it's been very long standing, since he was a child, really.
Mm-hmm. Okay. Thank you. Other question, though you said that his symptoms have largely resolved, but any sign that he's grinding his teeth?
No.
Okay, thanks. All right, so now we can move over toward suggestions, unless there's some other clarifying questions, but do people have any suggestions for resources or ideas that might be helpful for this young man and for his treatment team?
Well, this is Paige. I was just, the question about whether he had friends in recovery is really driving me to the point that he needs peer support. And it would be great if, I don't know if you guys have a CRS that can round and maybe meet with him along with the behavioral health specialist. But I think it would be really good for him to be talking, that that he's talking to somebody who's in recovery. And in particular, CRS. I mean, he might be meeting people at NA meetings, but that doesn't really help me. Like you never know what's at an NA meeting. So I think it would be really good for him to see a CRS. Or a peer specialist, especially at that young age.
Yeah, Paige, that makes a lot of sense to us. And Amy and I have been reaching out and trying to sort of figure out how we can, in our office here, how we can connect to CRS. So we recently had a meeting with Brooks Coca, and we're trying to, to figure that out. But we definitely, I think it's a great idea. We definitely need to figure out a connection for this patient specifically. Bill, do you have any recommendations about that?
I think Paige's suggestion is really important and a good one. We're working on that CRS thing right now, but so I don't have any resources internally in the program for that. But I'm glad you had reached out to Berks Coca because I'm not sure if they will be able to help out with that. But I think in that you're in Berks County, that would be the appropriate place for you to go with that.
Thanks.
Kevin, you mentioned that you had a stiff copay for the buprenorphine formulation that he was prescribed while he was inpatient. Is he on medical assistance or does he have private insurance?
He is currently under his father's insurance, but he is working on a medical assistance application, and I did resource out to the CCT team, the social worker, to assist him with that, and that is in process right now.
Great, because that does make the CRS thing more complicated also. But it is good to connect with the single county authority, which is your Berks Coca folks. For anybody else I think most of our primary care folks had to jump off, but that's our pathway to have people with medical assistance, uninsured or covered. All right, other suggestions out there?
Hi, this is Yamelisa. I think one of the important things, of course, will be, like Paige said, is getting him some peer support. But as that is in the works, at his upcoming appointment, having a more in-depth conversation about what his goals are, what his interests are, and how to link the two, and then also providing him with more information about the kratom, the risks that kratom can bring to him being on Suboxone at the same time, and really just where he's getting his information from. Because like Paige mentioned, it doesn't sound like he has many in recovery folks that are supporting his recovery. And, if he's being told, oh, just quick go on Suboxone to get off of the heroin, but here take kratom every day without understanding the risks, it's going to just be really important, especially, being that he's so young, and getting a more well-rounded, information to him, resources, and hopefully linking him to other folks that can reach him at this stage in his recovery.
Thank you. More suggestions, resources.
I can add to that, to Lisa's comment about the kratom. I do think it's a good idea to talk to him about that. Kratom is really complicated. I think the way I would explain it to him is that, as with any plant-based therapy, I can see the temptation to use something that seems natural, that grows as a plant, but we don't completely understand how kratom works. But what we do know is that it works in many different ways. So it's sort of like taking multiple types of medication at one time. And so to explain the mu effects, I would say that to him that kratom works kind of like an opioid, so kind of like heroin, works at the same place in the body that heroin works. And so that can get complicated with Suboxone, because if you combine the two, especially because he only takes the Suboxone once a day, what he could potentially be doing is precipitating withdrawal, meaning that you're putting yourself into withdrawal if you take the kratom and then take the Suboxone after that. And so I worry that maybe that's contributing to some of the bad feelings he's having in the morning, because it's been a long time since he took his last dose of Suboxone. So he's almost 24 hours from his last dose. He takes a some kratom for his symptoms and then takes his morning Suboxone, maybe he's making himself sicker by doing that. Another way that kratom works is sort of like clonidine. So I would explain that when we're in opioid withdrawal, we feel kind of hyper excited, sweaty and shaky and uncomfortable, and our heart rate goes up. And clonidine helps to calm all of that down. Kratom works very similarly, so I can understand why you would want to take something like kratom, because it does have some of those effects that can be helpful. But a simpler way to treat those symptoms would be to take a medication like clonidine, because then you know you're only getting that effect. And then the third effect that we know about is that it blocks serotonin, which is the chemical in your brain that helps you with any feelings of depression and sometimes anxiety. Because kratom blocks that, it might be making your anxiety and depression symptoms worse. And while I know you're maybe a little hesitant to take a medication for your depression, what I worry about is that kratom is actually making those symptoms worse. And so in that way, kratom works a little bit like some of our antipsychotic medications, which actually work on dopamine rather than the depression chemical in your brain. And so I think kratom might be making things really complicated. And our goal here is to really help you work through your goals and meet the goals that you have. And at that point, I would repeat back some of the things that you've mentioned that are important to him, and that I think kratom might be working against you at this point.
What's in your bag?
Thanks, Jillian. Angie, do you have any suggestions for this case?
Yeah, so I think the kratom feedback is really important, and just to put that in an MI frame, if that would be helpful. So you might just go in and ask him if it's okay to talk a little bit more about his kratom use first, and respect what he says to you. And then I'd affirm his decision in the past to talk to you about that, and how he's really thinking intentionally and consulting with the doctor about what he puts in his body. And you really want to affirm that he's brought that to you in the past, and that you're really proud of him for doing that. And then share that information about what you know about kratom, just the facts. Taking in low doses, it acts as a mild stimulant, and taking in high doses, it acts like an opioid-like receptor, and the information that Jillian had shared. And then say, what do you make of that? What are your thoughts on that? And as a 22-year-old that was using heroin all day, I'm sure, there's a part of him that doesn't trust the Suboxone, taking something one dose a day, and so those tendencies for him to continue to take and mitigate. But, maybe he can share a little bit about what kratom was doing for him. If I look at his case, he was diagnosed with ADHD at a young age. So the methamphetamine-like substances are helping him if he's not getting treatment for the ADHD, right? And so that by the drugs he was taking on the streets. And then, thinking about how he feels about his opioid withdrawals and the presence of kratom, which you're not really going to know until he begins to come off of that kratom, and therefore there would be some withdrawals. But at this point, what's most important is that he's talking to you about those things, and then you're able to intervene in the behavioral health provider. So just in these passages with him, your affirmations with him, asking for permission to talk about it, giving him factual information and saying, what do you make of that? And, what changes are you ready to make, or can we make together? And you as well being committed to making changes to medication management if that needs to happen too. The other thing is, I'm sure he has access to Narcan, but making sure he has access to Narcan, and just talking to him about harm reduction plans around relapses with the alcohol and benzos that he periodically uses as well, but not using alone, leaving doors unlocked if he's using, and if he has a safety net plan for high-risk times when he's going to use, who he can talk to, who he can reach out to so someone can check on him. That's all for me.
Thank you.
Any other suggestions for this case?
I can certainly talk about the wean, but I don't want to hear from other people, but we can come back to that.
Okay.
Yeah, I had a suggestion. I would just suggest putting some mental health supports in place, possibly like an intensive case manager or a certified peer support specialist that could help him sort of navigate the system and get some more resources as far as education and obtaining employment are concerned.
Great. And I think if I can chime in, you were asked a little bit about the tobacco use, and I think our suggestions are to address that in some way at every visit, but using the motivational interviewing. So the same framework that Angie was talking about, of asking, is it okay to talk about that, and being ready that if he says no, but it's easy, I think, for us as clinicians to become just as overwhelmed as our patients, and to put things on a back burner that suits our needs for it to be on the back burner right now, and it's not always clear when it's the right time for the patient. So keeping it from getting too far to the back burner may be helpful, and just making sure that you're asking, is it okay to talk about your tobacco use today? And if not, okay, maybe we'll take it up next time. But while many of our folks don't want to do that right away, I've been surprised that people are ready at a different time than I expected.
Yeah, I just want to add that here at the Counseling Center, we do have tobacco cessation services available, and we could certainly, at a point in time, Dr. McNeil, when you feel, it would be good to approach that. We can approach that and at least provide some consultation for him and let him know what those resources are. We can do some coaching with him on that, and work with him to kind of create that plan to get him to a better place with that. So I do think we can address that with you in terms of helping him. Again, just kind of look at his options, understand his options, and if he wants to move forward with that, we'd be certainly here to assist him with that.
Thanks, Bill. Would you also, just thinking about Gina's recommendation about that care manager to sort of assist in other ways, including help getting him a job, et cetera, is that something that you guys can connect him to?
Yeah, we can connect him with some resources for that, and make that part of the referral plan for him and the resource plan for him. So yeah, I think we can help with that as well. And I did make a note of that here in my notes for consultation with the counselor.
Awesome, thanks, Bill.
Bill, while we're on that topic, I'm curious because every county is a little different, every organization is a little bit different. Can you comment a little on your approach to co-occurring mental health disorders? And we've heard a little bit about what it looks like from the primary care side, that this guy's got some symptoms, he screened positive on some screening tools, and he seems to be really struggling with those symptoms, and they're long lasting. What does it look like from your counseling center's point of view with those issues, and what's your usual pathway to connect to the mental health, or to, Gina was mentioning a behavioral health, mental health ICM. How do you handle that?
A large percentage of, not unlike other facilities, a large percentage of our patients here at the program do have the co-occurring mental health disorders as well. And as you know, sometimes in early recovery, it's really difficult to kind of look at that depression or anxiety clearly until you get, you know, a little bit of time without the substance, when you can better evaluate how much of that is substance related and how much of that may just be the co-occurring disorder. As we look at those kind of issues here, we do a really intensive, if you will, or really comprehensive assessment on those issues to try and identify them as early as possible and to look at what resources might be appropriate for that individual. Sometimes primary care physicians are prescribing medications that are sufficient and are working well for the patient. Other times we will make a referral to a mental health facility, a behavioral health program, where they can see a specialist for that. We then get a release form so that we're able to consultatively talk to that person and understand what they're doing in treatment versus what we are doing in treatment and how that might overlap. Sometimes we are covering those co-occurring topics in groups simply because the group dynamics really require us to do that. But we try and link up to make sure that we provide as much as possible a comprehensive approach to that so that the patient's having both of those balanced, because really the balance of those at the same time is just so critical to make sure that that the recovery program is continuing to move forward, because without both of those in balance, it just makes it much more challenging for the patient.
Okay, we have a chat from Rob, and I'm going to read this out for you, Rob. In his experience, a lot of people in general, patients as well as consumers, are not aware that there's a connection between the nicotine and the cravings for opiates. So sometimes just educating people that this is the case can be enough to motivate them to address the smoking too if they're committed to stopping the opioid use.
That's great. Yeah.
Yeah, and back to the motivational interviewing. Is it okay if we talk about your tobacco use? And is it okay if I share with you some of the things that we know about how tobacco abuse might affect your opioid use disorder? Any more suggestions? I can't quite remember who we heard from and who we didn't, but if there's anybody else that has anything else to say.
I think with him asking about weaning off the Suboxone right away, I think that's really common. And I notice people, sometimes that's the first question they ask when, oftentimes when they're really kind of struggling and things aren't going well. And I think that speaks to the anxiety and how overwhelming it can be to begin that trajectory. And so I think it's a really natural question to ask. And the way I usually frame it is by kind of reflecting back their goals. So to discuss all of his goals and the things that he's working on. We've been talking about tobacco, that's one of them. And that as part of it, to support his recovery trajectory, the medication is there to help provide that little bit of a piece of extra support to help his brain heal and his body heal. And that in my mind, I think the best time to begin to think about weaning Suboxone, if that is what the individual desires, is to try to wait until that point in the recovery trajectory when pieces of life are really coming back together. So you've met your goals, you're engaged in some classes, you're healing relationships, you've been able to quit the tobacco, so you know you're past that challenging time. You've made it through IOP, and now you're in OP or maybe monthly counseling at the school counseling center, and that's going really well. And you're doing well despite, slowly reducing the number of counseling sessions that you're doing, that you're feeling supported. You figured out that despite some of the pressures at 12-step meetings, some of the stigma around Suboxone, that you figured out how to balance some of those issues. And so once those pieces have all come together to say, we'll be here to support you to do that wean, And if they're asking specific questions, I like to explain that sometimes we'll break up the dose. So instead of 1 dose a day, we'd maybe break up that tablet into quarters and take a quarter 4 times throughout the day. That way it's easy to remove one of those doses. And that just gives him a sense that, hey, we're not going to just pull that morning dose away from you. What we're going to do is provide you with some other medications like the clonidine I mentioned earlier to help you with any of those symptoms. So some other meds that can support you, and that we would do a slow wean so you never get to the point where you're just medications being pulled from you. That we would never stop a blood pressure, diabetes medication suddenly because people don't feel well when we do that. That all medications should be weaned slowly and carefully, and that we'll be here to support you if there comes a time when you would like to come off this medication.
Thank you.
Yeah. Yeah, I think Melissa brought up the question earlier of where is this person getting his information, and both the kratom and the question about when am I coming off the Suboxone are things that we hear frequently from community and sources of information there, and that the stigma about medication-assisted treatment is still pretty prevalent in many areas. So we hear people talking about using kratom to manage withdrawal symptoms and to detox, which is misinformation. It will stop some of your withdrawal symptoms, but it will cause some withdrawal symptoms because it causes dependence. But people think it's safe because you can buy it at the 7-Eleven in little green and red containers. So education about that can be key. And then we've had quite a few people who are looking for buprenorphine to do a rapid detox at home because they've seen that that's what people use in detox in inpatient settings. So they want to manage that at home, but we haven't found that people succeed very well with that. Other settings are doing really pretty well, I think, with some outpatient detox protocols, but we have not succeeded. And we can talk about that, and I'll be looking for some more evidence about who actually is succeeding with that and what kind of support do they have that makes it different from our office here. But we try to be as clear as possible that we are doing medication-assisted treatment for a long period of time, not for a short detox, and that we want to see you on a stable dose for a good 6 to 12 months, and that we'll talk about weaning when you're ready. So the same sort of approach that Jillian is talking about, that this is patient-directed after we get on a stable dose and things are going well. But before that, we try and encourage people to stay on a dose that curbs their cravings and withdrawal symptoms. Okay, it's 8:53, so I think we don't have time right now for Jillian's case, but we're going to start with that one next month. So we'll start with a case, and we'll use the same pattern that we'll ask clarifying, do a summary, clarifying questions, and suggestions. We will summarize the suggestions that were brought up here. I've got 7 categories of suggestions, and we'll get those out to the group, specifically for Kevin and Amy, for your team, to address this particular guy's issues, but we'll send them out to everybody so that you get a chance to sort of think about, well, what does that look like for my cases? And they will be posted on the NHCLV ECHO website. If you go to nhclv.org, in the About section, there's a drop down for ECHO, and that's our Project ECHO website, and we'll be sending that website link out to you all also. We have all the ECHO sessions posted. You can, if you miss them, you can go find them there. And then any other materials or resources as we're looking to support our suggestions with evidence, we'll post those on the website as well. Let's do a brief closing if you have some feedback for us about this process so that we can make it better for you. Oh, and I forgot to say, we will be sending out along with that follow-up email, I'll get this down eventually. Also the link to the survey, there's a red cap survey. Fill out that survey if you're interested in claiming CME, that's good for the nurses and for the doctors, or CEUs for social work. We're hoping that that the final review goes through today so that this session counts. I'll keep you posted on that one. Okay, so as I call you out, just a chance to give us your parting thought for the day. So I'm gonna start with the 484 phone number. I'm not sure we know who you are. Dear 484 735 4740. Are you there?
Is that attached to someone who's already?
That may be. That might be somebody's audio. All right, I'm going to go from the bottom of my screen page.
This was great. I'm feeling really proud of Hamburg, what Kevin and Amy are doing. I just think it's amazing that, you know, we have a start out there, that there's primary care physicians who are having these conversations with 22-year-olds. It's just, I'm so psyched. That's it.
Bill.
Yes. As always, great discussion. Picked up Dr. Jillian, I especially liked your overview of the kratom as it relates to Suboxone, and I think that can be very useful for an explanation. I wrote it down as quickly as I could. I like the way you were able to break that down and simplify it, and I think that was very valuable. And as was all the discussion about the case, and usual, time well spent here at Project ECHO.
Thank you, Bill. Candace, please feel free to introduce yourself and your words of leaving. Unmute Candace. Candace, we're trying to unmute you. Still mute. I believe this is Candace from Hazleton, so I'd love to confirm that. So we're not able to unmute her. Candace, we'll come back to you, but if you can chat into the chat again, we can read that out for you. Amy Smith.
Thank you. This was great. And as I was sitting here listening, with now having to do all of medical education online, I was thinking that maybe what a great opportunity this would be for students to hear these conversations and be part of it. That maybe Jillian, Abby, Kevin, coming up with some kind of independent study for students who are no longer able to be in the clinical setting. I think something like this would be a great opportunity. I want to thank you, Abby, for making this happen, and Kevin and Amy for sharing. So thank everybody.
Thanks, Amy. It's a beautiful team effort. Kim.
Hi. I just wanted to say I thought, as someone who is a non-clinician and doesn't deal directly with this most of the time, that I got a lot of really great information. I think it'll be helpful as I deal with the Connection School to share some of this. So again, thank you very much.
Great, thank you, Kim. Diane.
Thank you very much, everybody. And as my evaluation hat, please look for an email from Naomi in the future, like in the next day or so, for a post survey so we can see how to make this better.
And we will be reviewing all of that, and it's connected to your education credits. Barb. Thank you, Diane.
Let me unmute. Like him, as a non-clinician, this was, I learned a lot, as I do every time I spend any time with you, Abby. And
I enjoyed it. It was sort of, there's a balanced aspect to it. And I particularly liked seeing Jillian's little dog jumping on her lap.
Thank you, Barb. Rob.
Hi, everyone. So I thought this was just great. Everything about it was great. I thought the facilitation was great. The case itself was great. I love seeing the various disciplines here on the phone talk or in the room talking. I don't know most of you, and my role at HRSA in the Office of Regional Operations is mostly external affairs. A big piece of that is helping keep HRSA informed about the kinds of things that are being discussed in the clinical settings, and this is a really a great way for me to be informed and do that. So I am thankful and appreciative.
So glad to have you with us, Rob. Elaine, on the move.
Sneaking away from the kids. Yes. Well, thank you for that. I appreciate it.
So glad to have you and watch your domestic life. Paige. Paige, you're up. Oh, you did Paige. Sorry. Kevin and Amy.
Sure, I'll go. Starting this venture with Kevin was definitely a new nursing venture for me. I've been a nurse for over 20 years, and it was definitely something that I was not comfortable doing. So I appreciate this, and I think it's a great learning experience for other nurses also.
Yeah, thank you for this. This was really helpful, and not just the content, which was excellent in terms of the suggestions, but also there was some modeling going on as well, which I thought was really, really helpful to me. So I really have a better sense of, when I see CL next, I think it's next week. Is that right? Anyway, yes. Next week. Yeah, I really have a better handle on what I should do next. So thank you.
Wonderful. And Amy, may I mention that Jasmine here has been doing the nurse care management at NHCLV for years. Yeah, since we started. So is available for questions or for companionship on this journey.
Thank you. I will definitely reach out to you.
Thanks, Sue. Great. Dan, our Pittsburgh pal.
I just want to say thanks again for inviting me to attend this. It was really helpful for me. I felt I learned a lot. On the side of things that I'm in, on a research project where we generally use ID codes, treatment where it's hard to remember that these are real people. So being able to see this in action and seeing all the work that aiding on getting the best possible care to these patients.
Thank you, Dan. It's great having you with us. Melissa.
Hi, so I want to say thank you. I'm very grateful for today. I'm usually in the room with you guys, so this was a little bit different for me. But I really did appreciate all the feedback, being able to listen to the case, the didactic, the conversation is continuing. We have a lot more participants in this ECHO than we have had in many others, so this was awesome as well. And always having, Abby, Bill, Jillian on board is amazing, and the rest of you guys as well. So thank you.
Thank you, Melissa. Glad you joined us. Angie.
Yeah, this is wonderful. Great job, NHCLV team. And Kevin, it was a wonderful case. And thanks for allowing us all to dive into it with you and be open to all of that. It was great to be a part of the morning.
It's always great to be with Angie at any time. Jillian.
This has just been a wonderful morning. It's so nice to be able to be part of this. And it's just, ECHO is always a reminder to me that it takes a village. And I always learn from hearing other people's points of view and other people's ideas and even other people's questions. So that our primary care physicians are considering doing this work, I think it's just incredible.
Thank you, Jillian. Naomi.
I want to say thank you as well for letting me be part of this team. I'm learning a lot of new things and meeting a lot of new people as well.
Big thanks to everyone for coming onto the Zoomverse this experiences, and I'm looking forward to what the rest of the year holds and what information we can share with each other and the changes that we can get our community.
Thank you. And this is Abby, and I want to thank all of you for coming together during this strange moment of uncertainty. Doing the work that we know has to keep happening no matter what's going on around us gives me a real sense of power and potential. I think we can change the world, and I need it. So deep gratitude to all of you, and we'll see you next month. And for NHCs, we are available. So questions about the Medicans on Tiger text, or if you have some emails, Kevin and Amy can tell you all about what this looks like in an LVPG practice. Paige from her recovery community linkages and so on. Angie for the behavioral health folks on the teams, and we'll be talking a little bit more about what those teams look like. Behavioral health linkage or behavioral health strategy questions. Angie Callistra is the expert among us. Yamalisa and Bill Rowan for what does treatment look like in the community, and what are the resources at the community level, and what's the great work that's been happening there all along as we integrate primary care into the care continuum. Go out there, be safe, stay at home, I guess is what I mean by go out there. Wash your hands, pet your dogs, and have a fabulous day.
Thank you, Abby. Thanks, everyone.
Abby, did you want us to stay back to debrief?
So it looks like it's just you and me, because Kevin and Jillian left. But Yamalisa, you're still there, right?
I am. I'm trying to figure out how to get home.
If you don't, stay right there.
Oh, okay. Sure.
Okay.
I think, is there just a few more people on?
Yeah, I think
I think we can